approval, where I would, before I infused any fluid into the eye, before I had done any manipulation, I held the probe inside the eye at 2 different locations. One was adjacent to what I thought was the lens, but I'm going to tell you it's really adjacent to the lens in the pars plana. So just keep that in mind. And the second location was in the mid-vitreous cavity. And these were the results. So oxygen tension is on the y-axis, and on the x-axis we see 2 measurements before vitrectomy surgery. And they're both low. So I told you that natively, in the normal undisturbed eye, oxygen tension is actually very, very low. And then after vitrectomy, we now have a fluid-filled eye. So we have all this balanced salt solution, and the levels are exceedingly high. That p-value is 10 to the minus 14. This is like dropping an oxygen bomb on the inside of the eye. The eye never sees oxygen levels like this under normal physiologic circumstances. But I want to go back to before vitrectomy, because I have 2 columns. One is adjacent to the lens, and it's actually closer to the iris and the ciliary body. And the other one is in the mid-vitreous cavity, right in the center. And the difference between those 2 is actually statistically significant. And that means that if it's 9 millimeters of mercury near the lens and 7 millimeters of mercury oxygen in the center, there's an oxygen gradient. And an oxygen gradient can't exist if we're relying only on diffusion of oxygen through the vitreous gel, which is 98–99% water. So something else has to be going on. Diffusion is not the mechanism here. And so we hypothesized that in order to get an intraocular oxygen gradient, the vitreous had to consume oxygen. So, how would we test that? Well, you take a oxygen impermeable glass tube and you put vitreous inside of it with one of these oxygen sensors, and you hook it up to your machine, and this is what happens. We did this in the lab first, and we used cadaver vitreous, and at 0 minutes, the oxygen tension is very, very high, and then within 2 hours, it goes to 0, and that means that the vitreous is consuming oxygen. Who knew? And this is cadaver vitreous, so it's not even alive. And we can boil this vitreous, and it still consumes oxygen just like this. So it's consuming oxygen in an acellular manner that doesn't require being alive. We hypothesized this equation. Now we have to go back to good old-fashioned chemistry, that if you take 2 molecules of oxygen and mix it with 2 molecules of ascorbate, or ascorbic acid, in the presence of the secret sauce, whatever that is about the vitreous, and we think it's metal ions, it becomes dihydroascorbate and hydrogen peroxide, but you never see the hydrogen peroxide. That could be damaging to the eye. It's immediately converted by catalase to 2 molecules of water and only 1 molecule of oxygen. So if we go from 2 molecules of oxygen at the beginning to 1 molecule at the end, and this cycles often enough, oxygen is going to be consumed. And the key here is that the ascorbic acid, the ascorbate, is also going to be consumed. Well, let's talk a little bit about ascorbate in the vitreous gel. The highest levels of ascorbate anywhere in the body are in your vitreous gel. And the levels are 40 times higher than that found in the serum. And that occurs because there's active transport mechanisms taking all the ascorbate from your blood into the vitreous gel. And we've known this since the 1950s. And it was speculative. No one knew why there were such high levels of ascorbate in the vitreous gel, and I'll say, until now. I don't think it's that much of a mystery now. So we started experimenting with some cadaver vitreous again, and we saw that this oxygen consumption curve, how fast the vitreous gel consumes oxygen, depends on the concentration of ascorbate. Our ascorbate levels in a normal healthy vitreous is about 2.2 millimolar, and this first graph looks exactly like the one I showed you of the cadaver vitreous. But look, if we have 10 times less, the vitreous gel isn't consuming oxygen anymore. And if we have more, the oxygen consumption curve is very steep. And we can vary the rate on a linear basis simply by varying the amount of ascorbate in the vitreous gel. So remember that, because that becomes important. So we played around with cadaver vitreous, and we wanted to know if this is true in vivo. So I went back to the operating room with an IRB approval, and I started taking out vitreous from my patients right at the time of surgery. We set up a little lab right next to the patient on the stretcher, and I would remove 0.3 C's of undiluted vitreous. We'd put it in an oxygen-impermeable glass tube, and these are the results on the first 6 patients. The oxygen starts very high, and in general, within 2 hours, it goes down to 0, and vitreous consumes oxygen. So this is patient number 16. I ended up doing this in about 67 patients. This is a typical 55-year-old woman. She's undergoing a vitrectomy for macular pucker. It's her first vitrectomy ever, and she has a very nice oxygen consumption curve. And that's what we expected to see until we did patient number 19. She's 78 years old. She has recurrent retinal detachment. She's already had 2 prior vitrectomy surgeries. She's got no vitreous in her eye. It's basically aqueous. And there's no consumption of the oxygen. And so we looked at this a little bit more closely, and the lavender bars on the left are eyes undergoing this first-time vitrectomy with very gel-like vitreous. And the maroon bars on the right are the eyes who have had previous vitrectomy, and really there's very little vitreous. And you can see that a gel vitreous consumes oxygen more quickly at every single time point. So this begs the question, is the vitreous gel important? Were we born with a gel for a reason? Why isn't it aqueous humor? It's a vitreous gel. So we wanted to grade vitreous, and there's no system for grading vitreous, so we made one up. And we said, if it's more gel-like, you get a 1, and if it's more liquid-like, or a post-vitrectomized eye, you get a 5, and 3 would be somewhere in the middle. So again, 1 is gel-like, and 5 is very liquid. And we graded the vitreous gel blindly. We had 2 masked observers grade the vitreous gel as we were removing it from the eye, and then we measured the oxygen consumption. And if your gel was a 1, 2, or a 3, i.e. it was a very gel-like vitreous, it consumed oxygen very, very well. That's the bar on the left. And if you were a 4 or a 5, it consumed it less well. You had a liquid vitreous. And then if you were a re-op, if you had your second vitrectomy, so you're basically aqueous, it consumes the vitreous gel even less. So this got us thinking again, what about ascorbate? Because I just told you ascorbate's very important. Well, when we look at patient number 16, the ascorbate levels are very high at 2.6 millimolar, and ascorbate gets consumed in this reaction, so at the very end it's 2.1 millimolar. Oxygen gets consumed, and ascorbate gets consumed. Let's look at patient number 19. Her ascorbate concentration at the beginning was 0.21, and at the end it's 0.07. Very little oxygen consumption because she doesn't have a lot of ascorbate. Yet the ascorbate she has is still being consumed. So when we looked at gel-like vitreous, again, it's getting that grading of a 1, 2, or 3. The ascorbate levels are very, very high. And if you were a vitreous grade of 4 or 5, it's lower. And if you were undergoing your second vitrectomy, where it's mostly aqueous, the ascorbate levels are very, very low. And if we put the oxygen consumption curve right next to the ascorbate curve, they look almost identical. It doesn't happen by accident in nature. So here's our theory, that we were born for a vitreous gel, with a vitreous gel for a reason. What this cartoon is supposed to illustrate is that those red things are the capillaries on end in the retina that are continually exuding oxygen. And when you have a vitreous gel and there's an attached cortical vitreous, it's holding the oxygen along the retinal surface because that's where you want it. The retina is very highly metabolically active. It's going to need oxygen. And the gel prevents convection currents. It's holding the oxygen along the retina, and any oxygen that gets loose is going to be consumed by this ascorbate-dependent chemical reaction. But let's say you have a vitrectomy surgery, or you have vitreous liquefaction with a PVD. Now you have fluid currents. There's actually cycling of the oxygen within the eye. So there's more oxygen being carried from the retinal surface and mixing within the vitreous cavity, and if the oxygen is going to be consumed, the ascorbate is going to be consumed. But ascorbate enters the eye at a limited rate, and so the ascorbate levels are going to go down, and when the ascorbate levels go down, it doesn't consume as much oxygen. And now the oxygen from the retina can migrate anteriorly and affect the lens. So we were born for vitreous gel. We were born with a vitreous gel for a reason, and there's a difference between diffusion and flow, and the gel cuts down on the mixing, because continuous mixing with oxygen will actually quench or consume the ascorbate. And in a liquid vitreous, if there's less ascorbate, there'll be less oxygen consumption, and the intraocular oxygen tension will go up. Okay, so that was point number one. I hope I was able to convince you with point number one. Point number two is that vitrectomy surgery raises intraocular oxygen tension, and the regulation is lost, and I only have one slide for this point. So we went back to the operating room, and I would measure intraocular oxygen before vitrectomy, before I'd done any interventions, and those are the numbers in black on the left. Near the ciliary processes, it's 3, behind the lens, it's 9, in the midvitreous cavity, it's 7. But then I went back, and I measured it, not right at the end of that case, but I did it in people at their second vitrectomy 3 months later, 3 years later, 7 years later, and it was 13 wherever you measured it in the vitreous cavity. And so there's no gradient anymore, and so this oxygen regulation property has been lost because we have a liquid vitreous and it's not consuming the oxygen, it's not creating a gradient. So, point number 3 is that elevated oxygen leads to nuclear sclerotic cataract. And I don't need to tell you that. That's fairly well established, that it's associated with increased oxidation and aggregation of lens proteins. And what I tell my patients is that the price you pay for taking a breath every day of your life, as a little bit of that oxygen works its way to the crystalline clear lens in your eye and causes it to oxidize, much like iron rusts or an apple turns brown on the kitchen counter. And it's the older nuclear proteins that are the most susceptible to this oxidation. And an interesting fact, and this is what got us, one of the things that got us started on this whole oxygen hypothesis, is that the #1 complication from hyperbaric oxygen chamber treatments is nuclear cataract. And if you have people undergoing hyperbaric oxygen chamber treatments, what you find is that they're going to describe first that myopic shift that people get, and then they get the opacity. And when they stop their hyperbaric oxygen chamber treatments, the myopic shift goes away, but they still have that opacity because those nuclear proteins have been permanently oxidized. The second thing is that at the time of vitrectomy, we were able to show that at the end of surgery, there was an elevated intraocular oxygen tension, and that these eyes went on to get more oxygen-mediated nuclear sclerotic cataract. We published that in AGO in 2005. So this is the oxygen hypothesis right here on this slide. This is the most important slide I'm going to show you. Vitrectomy surgery is equivalent to immediate vitreous liquefaction. You're just giving someone a liquefied vitreous instantaneously as opposed to it taking years and years and years. Age-related vitreous liquefaction is associated with an increased risk of nuclear cataract independent of age. And we did this study in 2004 with 100 cadaver eyes. We cut them in half, we took out the vitreous gel, we put it through a grate so that we could measure the liquid part or the gel part, and we found that liquefaction, independent of age, was the primary determinant of how much nuclear sclerosis an eye had. So loss of the vitreous gel through age-related liquefaction or surgery allows oxygen from the retina to reach the lens of the eye, leading to nuclear sclerotic cataract. So that's the oxygen hypothesis for age-related cataract formation. So what about glaucoma? So we were doing this work in like 2003, 2004, 2005, and then Stanley Chang at Columbia gave the Jackson Memorial Lecture at the 2006 American Academy of Ophthalmology meeting. And hardly anyone has much experience with vitrectomy surgery as Stanley does, so he was able to look over a 30-year history of doing vitrectomy on people. And he found that after vitrectomy, long-term, if you follow these people long enough, that previous glaucoma suspects had a higher intraocular pressure in the operated eye rather than the fellow eye. And that was highly statistically significant. And he found that 68% of the 34 eyes that developed glaucoma after vitrectomy were the ones that actually had the surgery. And that in eyes with previous glaucoma, a greater number of medications were needed to now control the IOP in the operated eye as opposed to the other eye. So he has all these suggestions that vitrectomy is somehow leading to glaucoma, and he found that the presence of the natural lens at the time of vitrectomy was associated with a 28-month delay in the onset of glaucoma. Now that last bit there in yellow is because I just told you that the vitreous consumes oxygen. Guess what? The lens does too. And the lens can protect itself to a certain degree from oxidative damage, but not over the age of 50 very well. And if you take out the vitreous gel and you take out the lens, you're going to really raise intraocular oxygen tension, and it can lead to glaucoma. So that's what I'm going to show you next. This is in a native eye. These are measurements taken by a glaucoma specialist at WashU, who I got interested in this work. Her name's Carla Siegfried, and she's really done a great job. At the angle, if you measure oxygen tension, it's 12 in a normal eye. These are eyes undergoing cataract surgery with no history of vitrectomy, no history of glaucoma. It's 12. So in the normal eye, it's about 12, 12.9. So if you have done a vitrectomy, it goes up slightly to 15.1. If you only do cataract surgery, it goes up slightly to 15.4. But look what happens if you have an eye that's undergone both a vitrectomy and cataract surgery. It almost doubles. It's now 24.7 millimeters mercury pressure, which is more than twice what it should be, right at the area of the trabecular meshwork. So the vitreous gel and the crystalline lens consume oxygen. That's their role, to keep intraocular oxygen tension low and prevent oxidative damage to the inside of the eye. If we take out both, if we do a vitrectomy and we take out the lens, then we're going to significantly elevate intraocular oxygen. And at the angle, now the trabecular meshwork is exposed to these extremely high levels of oxygen that it's never been exposed to before. And that probably accounts for 15 to 20% of what we're calling primary open-angle glaucoma. And what I want you to think about is the old days of aphakic glaucoma. These eyes didn't have a lens. They had a very, very liquefied vitreous, and they were extremely refractory to treatment. Okay, so number 5. Elevated oxygen is beneficial for VEGF-mediated retinal disease. And this is the part we all like, because it makes retina specialists look good. And the retinal disease and the oxygen hypothesis has to do with VEGF. It's all about VEGF. Because I just told you, if we do a vitrectomy and we increase intraocular oxygen, oxygen is the most potent anti-VEGF agent known to man. With respect to Lucentis and Eylea, oxygen is the most potent anti-VEGF agent known to man. So let's look how this works in diabetic retinopathy. So factor X was identified as VEGF by this landmark paper in the New England Journal of Medicine. And we often see patients like this who have a lot of neovascularization on the disc, and we put in laser. This is the good old-fashioned days of laser where we really didn't have VEGF injections, so people got really big laser. And I love this slide when I'm teaching residents because I ask them, how does laser work? And laser works in 3 ways. Number 1, it kills the ischemic tissue, so it can't elute VEGF. Number 2, it's killing healthy tissue, so it's not consuming the available oxygen. And number 3, across this chorioretinal scar, you will get diffusion of oxygen from the choroid that in many cases is less ischemic than the retina. And so the point is here is that panretinal laser photocoagulation alters intraocular oxygen and is the only long-term fix for people with ischemic retinopathy. So what about vitrectomy surgery? Because I just told you that it raises intraocular oxygen. And so we've all taken these terrible diabetics, and we saw a very nice case of a horrible diabetic earlier, and we can make them look like this, and then they see again. But the key is you have to put in laser. If you didn't put in laser, you would not be changing the intraocular milieu of being one that's pro-VEGF. You would still have rubiosis, and these eyes would go downhill. So these eyes do very, very well if you add PRP, because what you have to do is change the intraocular oxygen tension. So do you remember doing vitrectomies for retinal vascular occlusive disease? Remember vitrectomy for sheathotomy, there was vitrectomy with radial optic neurotomy, there was vitrectomy with retinal vascular endocannulation, there was vitrectomy with peeling of the ILM for CRVO. What did all these cases have in common? They all had a vitrectomy. And they were raising intraocular oxygen, and so they were getting successful results. But in the real ischemic eyes, they were disasters and ended up getting rubeosis because you needed to put in PRP to alter that intraocular oxygen tension long term. Still the only long-term fix. What about AMD? AMD, I'm old enough to remember the days where we would do laser, and then we were also in St. Louis kind of the head of submacular surgery. The submacular surgery trials showed that vitrectomy didn't help people with macular degeneration, but we learned an important point. In the days of laser, the recurrence rate was about 50%. And in the submacular surgery trials, the recurrence rate was about 23%, or about half. And could it be that vitrectomy was raising oxygen and that the intraocular milieu was more pro-oxygen and less VEGF? I don't know, but it's interesting to think about. There's a study in Iowa where they took eyes with bilateral macular degeneration, and for whatever reason, one of the eyes had a vitrectomy, and vitrectomy tended to be protective. And we talked about a little bit earlier in our discussion today that a PVD is protective against exudative AMD. That's the work of Suzanne Binder and others. And you have to think, does it have to do with getting a PVD or a liquefied vitreous that's raising intraocular oxygen and oxygen being a potent anti-VEGF agent? So, in summary, the function of the vitreous gel is to consume oxygen and regulate intraocular oxygen. So it has a very important biophysical property of being a gel. It has a very important biochemical property for consuming oxygen. When this function is impaired by vitreous liquefaction or vitrectomy surgery, the eye has increased molecular oxygen. And I say molecular oxygen because everyone's hypothesizing all these oxygen-free radicals. It's good old-fashioned O2. You can oxidize just with molecular oxygen. We're oxidizing all the time. It's molecular oxygen. So oxidation of nuclear proteins in the eye leads to nuclear cataract. Oxidation of the trabecular meshwork may lead to about a 15 to 20% incidence of primary open-angle glaucoma, but because oxygen is a potent anti-VEGF agent, increased intraocular oxygen benefits all these VEGF-mediated diseases that we take care of, the diabetes, the retinal vascular occlusive disease, and perhaps even AMD. So with that, I'll say that all this work was done as a great collaboration with some PhD scientists down at WashU, and it was funded by a lot of different sources, and I would be happy to take any questions.